some of the diseases and illnesses found in the HEMOC system. So first we have grading a tumor versus staging a tumor. So in grading a tumor, you have grade 1, 2, 3, and 4, progressing with each grade. In grade 4, the cells are immature, known as anaplasia. The cell of origin is difficult to determine. So with anaplasia, there is a loss of specialized features of a cell. This is seen in malignancy. Now, with staging a tumor, you have stage 0 through stage 4. So stage 0 is known as carcinoma in situ. This is most commonly seen in the breast. It's when a group of abnormal cells are found in the area in which they are formed. Now, you move forward to stage 1, where the tumor is limited to the tissue of origin. Stage 2, you have limited local spread. Stage 3, you have extensive local and regional spread. And then stage 4 is when distant mets has occurred. So, warning signs of cancer. So, use the word caution as an acronym to help you remember this. But any change in bowel or bladder patterns, any sore that does not heal, unusual bleeding or discharge, thickening or lump in the breast or elsewhere, indigestion, obvious change in a wart or mole, or a nagging cough or hoarseness. All right, so diagnostics. Biopsy is always the definitive means of diagnosis in regards to cancer. Also, very important that when a cancer patient has pain, you, 1, want to always assess the patient's pain, and 2, always remember that pain is what the patient says it is. Do not ever underestimate a cancer patient's pain. So chemotherapy kills or inhibits the reproduction of neoplastic cells in addition to killing normal cells. So we talk about this too in the medication section with HEMOC, but effects of chemotherapy are systemic because chemotherapy is usually administered systemically via IV. So the normal cells that are most affected include the skin, hair, and lining of the GI tract, resulting in alopecia, nausea, vomiting, mucocystitis, and myelosuppression. So mucocystitis includes inflammation and soreness of the gut and mouth, and then myelosuppression is going to include neutropenia, anemia, and thrombocytopenia. All right, so radiation therapy. So radiation therapy destroys cancer cells with minimal exposure of normal cells. And when you think about radiation versus chemotherapy, so it's effective on tissues directly in the path of the radiation beam. So side effects are going to be local skin changes and irritation. You might also have hair loss and altered taste. There are 2 different types of radiation. So there are external beam radiation or teletherapy, where the radiation source is external. This patient does not emit radiation and does not pose a hazard. Whereas internal radiation or brachytherapy is when the radiation source is internal. It has direct continuous contact with the tumor tissue, and this patient does emit radiation and can pose a hazard to others. So in brachytherapy, you can have an unsealed source of radiation and then a sealed source of radiation. So in an unsealed source, this can be delivered via oral, IV, or either like installation into a body cavity. It's not confined completely to one body area. It enters the body's fluids and it's eventually eliminated via secretions, which are radioactive and harmful to others. So the majority is eliminated within 48 hours. After that 48 hours, neither the patient nor the excretions are harmful. However, prior to that, the patient is radioactive and does pose a threat to others. Now, that was unsealed. Now, a sealed radiation source is when a solid implant is implanted into the tumor target tissues. So this patient is going to emit radiation while the implant is in place, but their excretions are not radioactive. So after the removal of the sealed radiation source, the patient is no longer radioactive And then you're going to dispose of that sealed radioactive source in a lead container. So, any patient that's receiving radiation therapy, nursing assignments should be rotated for those patients. So, you need to limit time to 30 minutes per care provider per shift. Also, lead shielding may be used to reduce exposure, and you are not going to allow pregnant women or children under the age of 6 into the room with a radiation therapy patient. All right, stem cell transplantation. So there are 3 different types of donor stem cells. You have allogenic, syngeneic, and then autologous. So allogenic is where the donor is usually a sibling or a parent. The marrow is transplanted immediately. Syngeneic, the donor is an identical twin. And then autologous is the most common type, which is where the patient receives their own stem cells that are often frozen for later. So, in that post stem cell transplantation period, the patient remains without any natural immunity until the donor stem cells begin to proliferate and engraftment occurs. So, stem cells are very similar to blood products. They're often given through a central line or an IV infusion. Post transplant, you're going to assess for any signs of infection, bleeding, neutropenia, or thrombocytopenia until that engraftment occurs. And then failure to engraft is if the transplanted stem cells fail to engraft. Then the patient unfortunately will die unless another transplantation is attempted and is successful. All right, so leukemia is a hematological malignancy. There are 2 major types, lymphocytic and myelocytic. So lymphocytic involves abnormal cells of the lymphoid pathway, whereas myelocytic involves abnormal cells of the myeloid pathway. So it may be acute with sudden onset or chronic. It affects the bone marrow, resulting in anemia, leukopenia, thrombocytopenia, and of course a decline in immunity. So patients with leukemia may have a loss of appetite, anemia. They may have overt or occult bleeding, such as nose bleeding, gum bleeding, and hematuria. They may have a lot of ecchymosis or petechiae, enlarged lymph nodes, bone pain, and then they will have a positive bone marrow biopsy that identifies leukemic blast phase cells. So, in infection in a patient with leukemia, infection most often occurs on the skin, the respiratory tract, or the GI tract. It can occur through auto-contamination or cross-contamination. And know that the white blood cell count will be low during the period of greatest bone marrow depression, which is known as nadir. Also, the platelet count will be extremely low, resulting in an increased risk for bleeding. So, in an immunosuppressed patient, infection is a major cause of death. So, monitoring for signs and symptoms of infection and trying to prevent infection is very important. So, in that same realm, you want to reduce exposure to environmental organisms, therefore reducing risk for infection. So this is why patients on the oncology floor aren't allowed any fresh or raw fruits or vegetables, no fresh flowers or live plants, and no standing water. Also, in a patient with leukemia, you want to encourage very small, frequent meals that require little chewing, and it reduces energy expenditure. Now, like I said, the platelet counts may be low, increasing the patient's risk for bleeding. The patient is at greatest risk for bleeding when the platelet count falls below 50,000, and then they will have spontaneous bleeding when the platelet count falls less than 20,000. At this point, the patient will need a platelet transfusion. All right, so lymphoma with Hodgkin's disease. So Hodgkin's disease is characterized by the abnormal proliferation of lymphocytes. It's a malignancy of the lymph nodes that originates in a single lymph node or a chain of lymph nodes. What you need to know about Hodgkin's disease is that you will have a presence of Reed-Sternberg cells in the nodes. Okay, Reed-Sternberg cells, associate that with Hodgkin's disease. This patient is going to present with night sweats. They're going to have a positive biopsy of the lymph nodes and a positive CT scan of the liver and spleen. Okay, multiple myeloma. So, multiple myeloma is a malignant proliferation of plasma cells within the bone. So, excessive numbers of abnormal plasma cells invade the bone marrow, thus destroying the bone. This can also lead to invasion of the lymph nodes, spleen, and liver. So, multiple myeloma causes increased levels of uric acid and calcium, which can lead to kidney failure. So, as a nurse with your interventions, you're always going to assess for bone fractures, hypercalcemia, kidney failure, and infection. The patient with multiple myeloma, their urine analysis is going to result in Bence-Jones proteinuria. Be able to associate that with multiple myeloma. This patient is going to have bone pain, osteoporosis, elevated calcium and uric acid levels, and kidney failure. So, the two things to know about multiple myeloma, well, one is going to be your urine analysis that shows the Bence-Jones proteinuria. Then you need to know that they're at risk for kidney failure because of the increased levels of uric acid and calcium. And then they're also at an increased risk for fractures. So it's very important to provide support while moving, walking the patient. And then you want to provide a hazard-free environment as well. In order to counteract some of the elevated uric acid and calcium levels, you want to encourage lots of fluid intake a day, up to 2 liters per day. All right, testicular cancer most often occurs between the ages of 15 to 40 years. Of course, early detection is key. Early detection is going to be made with monthly testicular self-exams. These testicular self-exams, they're going to be best performed right after a shower when the scrotal skin is very moist and relaxed. That's going to make the testicles easier to feel. So you want to instruct your male clients to lift each testicle, instruct them that it should feel like an egg, very firm but not hard, smooth with no lumps. Then they can place their fingers on the underside of the testicles and thumbs on the top, kind of rolling the testicle to check for any lumps or masses. So they should do this once a month, and then of course report any abnormalities. The patient with testicular cancer is going to present with painless testicular swelling. They might have a dragging or pulling sensation in the scrotum. And then late signs of testicular cancer are going to be back or bone pain, and then respiratory symptoms as well. Also, something to note about testicular cancer is that a history of cryptorchidism, or an undistended testicle, has been linked to the risk for testicular cancer. All right, so on the other round, we have cervical cancer. There are 3 stages. You can see them there. Risk factors include, of course, a history of cervical cancer, cigarette smoking, multiple sex partners. You're going to do your screenings with pap smears. These pap smears, they should be done annually if it's abnormal, or every 3 to 5 years if it's normal, depending on the specific testing that was used. So these female patients are going to present with painless vaginal bleeding, whether it's postcoital, after sex, or post-menstrual. They may have abnormal vaginal discharge, pelvic, lower back, or groin pain, and then they also may experience leakage of the urine and feces through the vagina. So different interventions for cervical cancer. So you have laser therapy, cryosurgery, and then you can get a hysterectomy as well. So laser therapy, it utilizes the energy from a laser beam, and it causes the tissues to vaporize almost. So it's used when all boundaries of the lesion are visible. Now, cryosurgery is the freezing of the tissues using a probe. It is very common for cramping to occur during the procedure. And then the patient will also have a heavy watery discharge that will follow the procedure for several weeks. They need to avoid intercourse and avoid the use of tampons while this discharge is present. And then with the hysterectomy, this is performed for microinvasive cancer. A vaginal approach is most commonly used. Post-op, you want to monitor for any vaginal bleeding, and more than 1 saturated pad per hour post-op indicates excessive bleeding in this patient. All right, so in that same realm, we have ovarian cancer. Ovarian cancer is rapidly growing, it spreads quickly, it's often bilateral. It is most common among white women ages 55 to 65. Ovarian cancer is often asymptomatic, and because most women are diagnosed in advanced stages, ovarian cancer has a higher mortality rate than any other cancer of the female reproductive system. So, this patient is going to present with abdominal discomfort or swelling. They may even be able to palpate an abdominal mass. They're going to have GI upset, vaginal bleeding, and then an elevated tumor marker as well. So, oftentimes with ovarian cancer, an exploratory lab is used to diagnose and stage the tumor. A transvaginal ultrasound may be done as a screening measure, but it is not definitive. All right, so endometrial or uterine cancer. So, this is a slow growing tumor that arises from the endometrial mucosa of the uterus. So, most often this is associated with a postmenopausal woman. So, it is very important to know that any postmenopausal woman, any woman who has been without any bleeding at all for a year, after that year, any bleeding, any spotting at all, that needs to be reported immediately. This patient is going to need an endometrial biopsy for the assessment of endometrial cancer. So certainly keep that in mind. So your assessment findings is going to be abnormal bleeding, vaginal discharge, maybe some lower back, pelvic, or abdominal pain, and then an enlarged uterus as well as seen in advanced stages. Risk factors for the development of endometrial cancer includes the use of estrogen replacement therapy, polycystic ovarian disease, late menopause, a family history of endometrial cancer, and then diabetes or hypertension as well. All right, so breast cancer. Breast cancer is classified as invasive when it penetrates the tissue surrounding the mammary duct and grows in an irregular pattern. So this patient is going to present with a mass, most often in the upper outer quadrant, which is known as the tail of Spence. It can be beneath the nipple or in the axilla as well. They may have nipple discharge, skin dimpling or retraction, and then lymphedema of the affected arm. So risk factors for breast cancer include advancing age, a family history of breast cancer, and then nulliparity, which is where a female has never given birth to a child. Obesity is also a risk factor. Just as with testicular cancer, early detection is done via self-exams. So you want to perform them monthly, about 7 to 10 days after your menses. You want to do it while you're in the shower. Of course, you're going to use the pads of the fingers to press every part of the breast. Use the right hand to examine the left breast and vice versa. You want to perform this palpation in a spiral motion and then in an up and down motion as well. It is also recommended for the female to stand and look in a mirror, assessing for any asymmetry of the breast. So, interventions for breast cancer, a lumpectomy can be performed where the tumor is removed. You can have a simple mastectomy where the breast tissue and the nipple are removed, or you can have a radial mastectomy where the breast tissue, nipple, and lymph nodes are removed. Now, very important to know that after a mastectomy, there are to be no IVs, injections, or blood pressures performed on the side of the mastectomy. So you do this in order to prevent any development of lymphadenopathy. All right, so esophageal cancer is a malignancy of the esophageal mucosa. So risk factors include cigarette smoking, alcohol consumption, and a history of Barrett's esophagus. Assessment is going to be dysphagia, painful swallowing or odonophagia, and epigastric pain. Now, gastric cancer is a malignant growth of the mucosal cells in the inner lining of the stomach. Risk factors include a history of H. pylori infection, a diet high in sodium, spicy, or processed foods, a history of smoking, and alcohol use. Now, for the NCLEX, I want you to know the difference between the early signs and the late signs of gastric cancer. So, your early signs are indigestion, epigastric pain, a feeling of fullness, and abdominal discomfort, whereas your late signs are weakness, fatigue, nausea, vomiting, weight loss, dysphagia, iron deficiency anemia, and ascites. So, treatment for gastric cancer, you can get a subtotal gastrectomy done or a total gastrectomy, which is removal of the stomach with removal of the esophagus, jejunum, and duodenum as well. Post-op, this patient is going to remain NPO for 1 to 3 days until peristalsis returns. They're going to have an NG tube placed and know that it is normal for the NG tube drainage to be bloody for about 24 hours post-op, and then it should transition to brown tinged and then to yellow and then to clear. Okay, so pancreatic cancer. Pancreatic cancer is a topic that hits home for me. So my father did pass away from pancreatic cancer. It is very highly malignant, rapidly growing. Oftentimes, symptoms occur so late that the prognosis is very poor. So in my father, he developed shortness of breath. His shortness of breath is why he went to the ER to be evaluated, and then he was found to have pancreatic cancer that had metastasized to the lung. So with pancreatic cancer, just keep in mind it's highly malignant, rapidly growing, and then the prognosis is usually very poor. So the risk factors for pancreatic cancer are going to be increased age, diabetes, smoking, a high-fat diet, or a history of pancreatitis. The patient is likely going to present with unexplained weight loss, maybe some clay-colored stools, abdominal pain, nausea, vomiting, jaundice, or they may present with symptoms secondary to the meds. So interventions for pancreatic cancer is going to include that of a Whipple procedure. So a Whipple involves the removal of the pancreas and the duodenum with the removal of the distal third of the stomach. So post-op from a Whipple, it's very important to monitor blood glucose levels for hyper or hypoglycemia because of the manipulation of the pancreas. So post-op, it's very important to monitor the blood glucose levels. All right, so intestinal tumors are tumors of the intestine. So whatever signs the patient is presenting with kind of points you in the direction of where the tumor is located in the intestines. So blood in the stool is the most common manifestation of any intestinal tumor, blood in the stool. Now, if you have diarrhea, that is indicative of an ascending colon tumor. If you have constipation or flat ribbon-like stool, it indicates a descending colon tumor. And then alternating constipation and diarrhea can indicate a rectal tumor. Complications of intestinal tumors include abscesses, bowel perforations, of course, intestinal obstructions. An early sign of intestinal obstruction, it's increased peristalsis and increased bowel sounds, which then become hypoactive as the obstruction progresses. All right, with a colostomy and an ileostomy. So after a colostomy or ileostomy is placed, it's very important to monitor the stoma site. You want to monitor for any unusual bleeding, any color changes, or necrotic tissue. So definitely know your stomas, okay? So know that a red to pink stoma is normal and healthy. A pale stoma means the patient probably has a low hemoglobin or hematocrit. And then a dark purple, blue, or black stoma means impaired blood flow or necrosis to the tissue. This requires surgical notification, immediate notification to the physician. Also note that post-op, the stool will initially be liquid and then it will gradually become more solid. So these patients are at an increased risk for dehydration and electrolyte imbalances. In a patient with an ostomy, you want to avoid any foods that produce excessive gas because that's going to make emptying that ostomy pouch a little more difficult. All right, so with lung cancer, lung cancer is a common target for Mets, unfortunately. So you have small cell lung cancer and then non small cell lung cancer. The most common causes are cigarette smoking and then environmental and occupational exposure. This patient is going to present with coughing, wheezing, hoarseness, shortness of breath, maybe some hemoptysis. So, in a patient with lung cancer or laryngeal cancer, airway is always going to be your most important priority. So, laryngeal cancer, obviously, it's a malignant tumor of the larynx. It's diagnosed via laryngoscopy and biopsy. Risk factors include cigarette smoking, heavy alcohol use, exposure to radiation, or exposure to environmental pollutants. This patient is going to present with hoarseness, sore throat, maybe a painless neck mass, dysphagia, or difficulty swallowing. They may have a foul breath odor and even a burning sensation in the throat. So, interventions may include a partial or total laryngectomy. So, with a total laryngectomy, a tracheostomy is placed, which it's a permanent airway opening. And in that situation, the trach is known as a laryngectomy stoma. All right, so with prostate cancer is a slow growing malignancy of the prostate gland. So the risk increases with each decade of men over the age of 50 years old, and for some reason it is more common in African Americans. So they may be very asymptomatic in early stages. Oftentimes, it's detected through an annual PSA level, which will come back elevated. They may have a hard pea-sized nodule and rectal exam. They may have very gross, painless hematuria. And then in the late symptoms, they will experience weight loss, urinary obstruction, and bone pain. So there are several different interventions that you can get done. Males can have a TURP procedure done, which is transurethral resection of the prostate. This is a palliative procedure. Post-op, you want to definitely monitor for transurethral resection syndrome, which is severe hyponatremia or water intoxication, which is caused by excessive absorption of bladder irrigation during surgery. So the signs of the transurethral resection syndrome include altered mental status, bradycardia, and increased blood pressure. The patient may also undergo a suprapubic prostatectomy or a perineal prostatectomy. So with a suprapubic prostatectomy, it's removal of the prostate gland through an abdominal incision through the bladder. So an abdominal dressing is placed afterwards. It may drain copious amounts of urine, and that dressing will need to be changed frequently. Also, continuous bladder irrigation may be prescribed, but you need to be sure to follow the orders very closely for that. Now, peritoneal prostatectomy is when the prostate gland is removed by an incision made between the anus and the rectum. So this does cause sterility, and oftentimes it can cause urinary incontinence. So post-op, you want to monitor for any arterial bleeding, which would be evidenced by bright red urine with clots. And then you want to monitor for venous bleeding, which would be evidenced by burgundy urine. So bladder cancer is malignancy of the bladder. Risk factors include cigarette smoking, exposure to radiation, exposure to industrial chemicals. The main assessment findings is going to be painless hematuria, which is your most common sign. And then you're going to have urinary frequency, urgency, and dysuria as well. This patient can undergo chemotherapy. So with chemotherapy, a chemo agent is instilled into the bladder. It provides a topical chemotherapy treatment with little systemic circulation. So the chemo agent is injected and retained in the bladder for 2 hours. So it's kind of neat. The patient rotates every 15 to 30 minutes. They'll start in a supine position and rotate every 15 to 30 minutes, which allows the chemo agent to touch all the walls of the bladder. So then after 2 hours, the patient voids, and then the fluids and then fluids are increased to help to flush the bladder further. So in this case, you are going to treat the urine as a biohazard. You're going to send it to the lab for monitoring. And then, of course, you want to disinfect the toilet and clean with bleach. This patient may have an ileal conduit place, which is just where the urine flows through the conduit. It is propelled continuously by peristalsis, and it's important to empty your ileal conduit pouch when it is a third full to prevent any leakage, and you're going to change the pouch every 5 to 7 days as long as it's not leaking. Following bladder surgery, it's very important to monitor the urine output very closely. So you always want to notify the MD if the urine output is any less than 30 mLs per hour. So your goal is going to be 30 to 50 mLs per hour. All right, so this is a list of your oncological emergencies. So it includes sepsis and DIC, SIADH, spinal cord compression. You can see the others there. It's very important to notify the physician immediately if any signs of these emergencies occur. So sepsis and DIC. So a patient with cancer is at an increased risk for infection, particularly infections of the bloodstream or sepsis. So DIC is a life-threatening problem that's frequently associated with sepsis. So you definitely want to maintain a strict aseptic technique. You want to monitor closely for any signs of infection or bleeding. Early phases of DIC are going to include the administration of anticoagulants, but as DIC progresses, you're going to want to administer clotting factors because hemorrhage is going to be your primary problem at that point. Now, SIADH is whenever tumors produce or secrete substances that mimic the action of an antidiuretic hormone. So mild symptoms are going to include lower sodium levels of 115 to 120, maybe some weakness or muscle cramps. Advanced symptoms are going to include weight gain, confusion, and extreme muscle weakness. More advanced serious symptoms are going to be related to water intoxication. So when sodium levels reach 110, you really have to be monitoring for seizures, coma, and even death may occur when the sodium level drops that low. Interventions for this patient are going to be fluid restrictions. You're going to increase their sodium intake, and of course you want to treat the underlying tumor with chemo or radiation. All right, spinal cord compression. This occurs when a tumor directly enters the spinal cord or impinges on the spinal cord. So it causes back pain and neurological deficits such as numbness, tingling. You can have a loss of vaginal and rectal sensation, and it can cause muscle weakness as well. All right, hypercalcemia. Hypercalcemia most often occurs with bone mets. It's often a late manifestation of malignancy. So early signs include fatigue, anorexia, nausea, vomiting, constipation. Whereas your late signs are going to be severe muscle weakness. You're going to have diminished reflexes, maybe paralytic ileus, dehydration, and even a change in the EKG. All right, superior vena cava syndrome. So this is commonly associated with lung cancer and lymphoma, but it occurs when the superior vena cava is compressed or obstructed by tumor growth. So symptoms are going to result from a blockage of blood flow in the venous system to the head, neck, and upper trunk. So early signs versus late signs, know the difference. Early signs of superior vena cava syndrome are going to be edema of the face. They might complain of tightness of a shirt or blouse collar, which is known as Stokes sign. And then late signs are going to be edema of the arms and hands, dyspnea, swelling in the veins of the chest and the neck. So for this patient, for the early signs, you're going to see that edema of the face, especially around the eyes. And then the symptoms become life-threatening because they can lead to airway obstruction, hemorrhage, and cyanosis. Okay, tumor lysis syndrome. So, this occurs when a large quantity of tumor cells are destroyed rapidly and intracellular components, including potassium and uric acid, are released into the bloodstream faster than the body can eliminate them. So, this results in hyperkalemia, hyperphosphatemia, hypocalcemia, and hyperuricemia. So, very important for tumor lysis syndrome to know that hyperuricemia may lead to kidney failure. Okay. All right, so we have our four different types of anemia here. Anemia is, of course, a condition in which the blood cells lack adequate, healthy red blood cells or hemoglobin. So the most common causes for anemia is acute blood loss. You can have decreased or faulty red blood cell production, or even the destruction of red blood cells can cause anemia. General assessment findings for all types of anemia is going to include weakness, fatigue, pallor. You might have slight jaundice as well if RBC destruction is occurring. You may also have tachycardia and cool extremities. So, iron deficiency anemia. Iron deficiency anemia is when iron stores are depleted. This results in a decreased iron supply. So, you're going to have the pallor, the weakness, fatigue. You're going to have low hemoglobin, low hematocrit. Your RBCs are going to be microcytic and hyperchromic. So, you're going to want to encourage oral intake of iron through foods such as spinach, liver, and red meats. Now, it's very important that you know how to take iron supplements for the NCLEX. This will be on the NCLEX. You want to take your iron supplements between meals for best absorption. You want to either take them with a multivitamin or a fruit juice, as vitamin C will increase absorption of iron. You do not take them with milk or antacids because those will decrease absorption. Side effects of iron include black stools, constipation, and a foul aftertaste. Okay, and then liquid iron can stain the teeth. It's very important to take liquid iron with a straw and to brush your teeth after. All right, so vitamin B12 deficiency anemia, also known as pernicious anemia. So it results from, of course, an inadequate intake of B12 or lack of absorption of ingested B12. So with pernicious anemia, it results in a deficiency of intrinsic factor, which is usually secreted by the gastric mucosa. That intrinsic factor is necessary for intestinal absorption of vitamin B12. So when there's a deficiency in the intrinsic factor, there's a deficiency in vitamin B12. Know your assessment findings for vitamin B12, folks. These patients are going to have a smooth, beefy red tongue, slight jaundice, and then you're going to see the paresthesias of the hands and feet. Folate deficiency anemia is whenever the RBCs are larger than normal, they're oval shaped, and this is due to an inadequate intake of folate or vitamin B9. So these patients are going to complain of indigestion, tinnitus. They may also have that smooth, beefy red tongue. So, like I said, causes can include a dietary deficiency or malabsorption issues that are found in like Crohn's or celiac disease. So, foods that are high in folic acid that you want to encourage are green leafy vegetables, any types of meat, and liver. All right, aplastic anemia, it may be primary, which means it would be present at birth, or it could be secondary. So it is a deficiency of all formed elements of blood, including erythrocytes. Diagnosis is determined via bone marrow aspiration, which shows the conversion of red bone marrow to fatty bone marrow. The assessment is going to include pancytopenia, which is where there's low erythrocytes, low leukocytes, and low thrombocytes. And they may have petechiae, bruising, pallor, weakness, and tachycardia. So in this patient, a bone marrow transplant may be needed.